I will present you a case that is still challenging and still being treated in our hospital. It of course involves ECMO, the burdensome course of ECMO, and at least for our center, and I'll show you a few things that we managed to resolve differently. So this is a guy who was born in Zagreb and who got married to a girl in a vicinity, who lived in a vicinity of Zadar, and he has been spending his last years in harvesting these beautiful olive trees. You can imagine that was a peaceful life, but his medical history is not peaceful. He has been burdened with ischemic heart disease for quite long years, and with multiple PCIs. And in the recent 7 years, he has been also seen by the doctors for congestive heart failure. This is biventricular heart failure, now in the frequent flyer state, with the most recent ejection fraction of 25%. And we knew about him that he has a medical history of epilepsy that was treated with drugs and no attack in the previous 20 years. His glomerular filtration rate was preserved. He has had a history of alcohol consumption, but he's free of alcohol consumption for at least 6 years. When we post hoc checked the last findings he had in laboratory in a local hospital, they was normal for lung function and injury, and of course for renal function. So he presented to a local hospital with a typical worsening of chronic heart failure, 7 days of dyspnea, orthopnea, pitting edema. He was actually dismissed a bit earlier than should be, as we heard in the previous talks here. So he was not completely decongested from the last hospital stay. But this time he was a bit hypotensive, and he also became oliguric, and the colleagues identified the lowering of ejection fraction, started some inotropes, and referred the patient to our colleagues that work on a regular ward as for planned pre-transplant workup. So the transfer was arranged, and the patient came, and our colleagues from the upper floors quickly identified that this was a crash and burn patient with cardiogenic shock, immediately started dobutamine in high doses and elevated noradrenaline, and but with no resolvement in blood pressure, and patient remained high oliguric, but still, because of his age, he was 60, we thought that all the viable options were available. So the quick heart team was set. Many of members of this heart team were on holidays because this was a holiday season in Croatia, and some of consultations were made by telephone. So the immediate decision was to proceed to salvage VA ECMO as a bridge to decision. So the typical configuration of VA ECMO was used, the 23 French venous cannula through right femoral approach, arterial cannula was 21 French, and 4 liters of support was initiated, and adequate perfusion at that moment was achieved. I was not at the center at that time, and I advised my colleagues to immediately start to check what the venting possibilities were, because with such a declined ejection fraction and as such a need for ECMO support, ECMO lung is inevitable. Patient got dialysis, lactate failed, but congestion of course occurred, and this is his chest X-ray with multiple patchy zones, so the action should be done. And so this is the only echo that I have. That is so the echo that I have is after implantation of ECMO, so you can appreciate really diminished ejection fraction, and the congestion is understandable. So what are our venting possibilities? We choose to skip the balloon pump at this moment because we thought this patient could need longer support, and this would not be adequate amount of venting. Impella has not yet been used at my center as a venting strategy. We had an option to call our surgeons to implant central ECMO, and there are LA venting LA venting possibilities because we have a really dedicated electrophysiologist team that transfers percutaneously through HR septum each day, and there is also a venting possibility retrogradely through aortic valve, which we have been using in Vinogradska for in one case, but generally in general cardiological community, this venting strategy has not been proven to be so efficacious. So the idea was to implant additional cannula percutaneously from the other side of the femoral region. This was ice control punction, and the tandem heart 21 French cannula was transferred to left atrium. You can appreciate here on chest X-ray the venous cannula that goes to right atrium, the other cannula that goes until it kind of crosses the column. In reality, there is additional radiolucent part of the cannula that sticks to the left atrium, so this is adequate implantation depth for this cannula. So this cannula is then attached to the venous side, to the drainage side of the ECMO, and then this leaves us a possibility to drain a left-sided heart also. By this configuration, we can adjust the amount of draining from the left and from the right side. The idea was that we could shift within days towards option with LVAD configuration only, so this could be a kind of a resolvement for our patient. I'm not sure if this should be called VVA ECMO, because this is not VVA ECMO, this is VLA ECMO, VLA ECMO, but for the sake of simplicity I will use this abbreviation. And if you haven't been checking your Twitter account lately, I have one information for you. I was not aware of this option. There is a ELSO pamphlet, or somebody really ripped their logo nicely, that suggests in such situations that the classic percutaneously introduced cannula, venous cannula, could be preformed on the table by using heat, bending the cannula to 45 degrees, and then percutaneously insert it through the septum. So some of the facets are within left atrium, some of them are within right atrium, and some of them are still within inferior vena. I think this is really feasible. This seems really nice to start venting immediately and to prevent decongestion. Of course, you are then stripped of the possibility to perform these small adjustments of how much of blood you should draw from a left or right side, but this seems really reasonable, and you avoid additional cannula there. So with this configuration, we managed to get decongestion. Shock was, of course, resolved, and the patient remained non-intubated at this stage, and he was completely mentally stable, and we started to practice physical therapy with him, and just as we tried to talk with surgeons about our strategies, he became shivering, the fever came here, and we found Enterobacter cloacae in his hemocultures. So I picked up a few phones. What are our options? I called Marco, I called my colleagues from Rebro, Daniel, and they both told me you should implant parallel ECMO and do the extraction, and maybe some heroic procedures to be fast and to stop the spreading of bacteria to the new ECMO. But I couldn't figure out what to do with the LA cannula, and this seems like too much for me at the moment, so I tried the other approach. We tried to really high dosages of antibiotics with concomitant usage of Seraph. I'm not sure if you heard about the technology. So Seraph is one of hemoperfusion devices that is currently available, but it is the only one that can attach both particles of bacteria and whole bacteria at its polyethylene beds. It is covered with heparin, so heparin-induced thrombocytopenia is contraindication for this technology. So we applied this technique with high dosages of antibiotics, and we proved to be successful. Our patient was free of fever. All the inflammatory markers fell, and we managed to get cultures negative within 2 days, and so he was really improving once more. And our surgeons accepted him for surgical procedure. And as far as this case is concerned, these were my 2 topics. I will, of course, for the sake of the case, explain what happened next, but I really kindly ask the panel to not focus for indication for future resolvement of the case, because these decisions on advanced heart failure options in my hospitals are currently led by surgeons. And we were struggling, they were forcing us to provide them PA catheter values that could resolve the dilemma: is this patient cardiac transplant, immediate cardiac transplant case or LVAD case? We could not provide them with adequate numbers, because even after 18 days this patient was still in the need of a high ECMO volume support. Immediately as we lowered the support, the systolic blood pressure on the left side fell towards 60 millimeters of mercury. So he was implanted the LVAD because they declined the immediate transplantation. Within week and a half, there was a driveline infection. There was a persistent heart failure. It was partially provoked by the volume overload that he acquired in the surgical ICU, and the possible consequence of that was renal or liver failure. He was then transferred again to our ward, and we managed to successfully resolve these issues, and he was transplanted on his 66th day. Everything well, except for, again, overtreatment syndrome in surgical ICU. Now I will show you only the things that we managed to resolve. So we managed to get rid of him of noradrenaline and vasopressin, which in my opinion were the ones that provoked paralytic illness that he was operated for, and of course they found nothing. We managed to get rid him of inotropes because he has a new heart, and all this time this patient had a low lactate levels. Of course he was not, his diuresis was non-existent, but when we got him free of everything, when he came to us he was not able to talk, and within 7 days we removed all the central lines, we removed nasogastric tube, he started to talk, started to speak, we stopped parenteral nutrition with the antibiotic stewardship program. We stopped the antibiotics, checked for the cultures, nothing came out. We resolved almost all issues with the liver, and he started to, his diuresis started again, and he's now in vigorous nutrition, and we are dealing with his pain management. He is still bed-bound, he is practicing within his bed. We don't still see the resolvement of his renal failure. His diuresis today is over 2 liters, but urea is still high. We have some issue with hepatic failure. He's producing ascites, but all the other factors are really okay. We have an issue with slow sternal healing, and we are still considering what to do with his home care strategy. Hopefully within a week or 2 we will improve everything and he will be able to walk and go home. So to conclude, for advanced heart failure, obviously patient selection is crucial, and we heard this from previous lection. Obviously, when regarding VA ECMO venting strategies for left ventricle, there are some viable percutaneous options. LAVA is definitely something that should be considered in the future time, and for infection control there are some potent hemopurification tools that sometimes can be used. Thank you.